Hello and welcome. Today we're diving into a complex and potentially serious complication following organ transplantation, thrombotic microangiopathy or TMA, specifically post-transplant TMA. This condition can significantly impact the long-term success of a transplant and requires careful attention. Post-transplant TMA has a multifaceted etiology. Often, it's triggered by medications, particularly calcineurin inhibitors like cyclosporin and tacrolimus, which are crucial for preventing organ rejection. However, other factors can contribute, including viral infections such as cytomegalovirus or BK virus, antibody-mediated rejection where the body attacks the new organ, ischemia, reperfusion injury suffered during the transplant process, and underlying complement dysregulation in the recipient. In some cases, it's a combination of these elements that sets the stage for TMA. Let's understand what happens in the body. At its core, TMA is characterized by damage to the small blood vessels, the microvasculature. This damage leads to the formation of tiny blood clots, or thrombi, within these vessels. These clots obstruct blood flow, causing ischemic damage to various organs, most notably the kidney. The process consumes platelets, leading to thrombocytopenia, and damages red blood cells as they squeeze through the narrowed vessels, resulting in hemolytic anemia, characterized by fragmented red blood cells called schistocytes. While exact figures are variable depending on the organ transplanted and the population studied, post-transplant TMA is a relatively rare but serious complication. It tends to occur more frequently in kidney transplant recipients, though it can affect other organ transplants as well. Identifying predisposing factors and actively monitoring patients post-transplant are vital for early detection and management. The signs and symptoms of post-transplant TMA can be diverse and nonspecific, often mimicking other post-transplant complications. Common symptoms include fatigue, fever, confusion, and edema. More specifically, patients may experience signs of kidney dysfunction, such as decreased urine output, increased blood pressure, and elevated creatinine levels. Easy bruising or bleeding might also occur due to thrombocytopenia. Neurological symptoms like headaches, seizures, or visual disturbances can also manifest, highlighting the systemic nature of the disease. Diagnosing post-transplant TMA requires a multifaceted approach. It starts with a thorough clinical evaluation, carefully considering the patient's medical history, medications, and current symptoms. Blood tests are crucial, specifically looking for thrombocytopenia, hemolytic anemia with schistocytes, and elevated lactate dehydrogenase, or LDH, a marker of tissue damage. Kidney biopsies often provide definitive confirmation, showing characteristic microvascular thrombi and evidence of endothelial damage. Additional tests may be performed to rule out other potential causes, such as infections or drug toxicities. While there aren't strictly defined types of post-transplant TMA in the same way there are with other diseases, it's helpful to consider the underlying causes when categorizing them. For example, we might distinguish between calcineurin inhibitor-induced TMA, antibody-mediated TMA, or complement-mediated TMA. Understanding the predominant mechanism driving the TMA is critical for tailoring treatment effectively. The treatment and management of post-transplant TMA are complex and often require a multidisciplinary approach. The first step usually involves reducing or discontinuing the offending medications, such as calcineurin inhibitors, or switching to alternative immunosuppressants. Plasma exchange, or plasmapheresis, can be beneficial in removing harmful antibodies or complement factors. In some cases, targeted therapies such as eculizumab, a complement inhibitor, may be used, particularly when complement dysregulation is suspected. Managing blood pressure, preventing infections, and providing supportive care are also crucial aspects of the treatment plan. Preventing post-transplant TMA starts with careful patient selection, minimizing ischemia, reperfusion injury during the transplant procedure, and judicious use of immunosuppressant medications. Regular monitoring of blood counts, kidney function, and complement activity can help detect early signs of TMA. Tailoring immunosuppression regimens based on individual risk factors and closely monitoring for drug toxicity are also vital preventive measures. The prognosis of post-transplant TMA can vary significantly depending on the severity of the condition, the underlying cause, and the promptness of treatment. Early diagnosis and intervention are key to improving outcomes and preserving graft function. Recent research has focused on identifying biomarkers that can predict the development of TMA, as well as exploring novel therapeutic targets, particularly within the complement pathway. Further advancements in personalized immunosuppression strategies hold promise for reducing the incidence and severity of this challenging complication, offering hope for improved long-term outcomes for transplant recipients. Thank you.